Hello, everyone. My name's Julia Wood. I have big shoes to fill today. I'm really excited to be here filling in for Mel Dyson. But I know that in that I do have a large role to fill because Mel is so amazing, and I'm really flattered that she asked me to step in for her today. So my name is Julia Wood, and I am an occupational therapist and also an ambassador for the Davis-Phinney Foundation. And so I'm really excited to introduce this topic today in a webinar format. A topic in healthcare, I think, that is really emerging is the role of women in different conditions and different treatments. And so we're going to talk about women in Parkinson's today. And so I'm joined by my friend and colleague, Dr. Michelle Fullard, and we're going to go over some housekeeping items before I introduce her today. So you're going to notice at the bottom of your screen that there is a chat icon. If you click it, a window will open on the right and you'll be able to chat. Look at the bottom of that screen and you'll see a blue bar that lets you choose who you want to see your chats. If you want to chat something to me privately, please be sure to select Post Privately. If you want everyone to see it, you can select all panelists and attendees. I suppose if you wanted to chat something about me, if you want to make fun of me to other panelists, you could do that. I'm teasing as well. So you'll also see a Q&A icon, and this is where I'd like for you to type your questions for Dr. Fullard. However, I'd love it if you could hold off on typing any questions in until it's time, and there's a good chance we'll answer questions during the conversation. So let's wait until kind of the end or hold questions until the end, and you can type those into her. And I have a lot of questions that have come in ahead of time as well that I've made sure are already covered in the content, and then I'm going to make sure and kind of prompt during the conversation today as well. So let's get started. We're joined today by Dr. Michelle Fullard. She works in the Movement Disorders section of the University of Colorado, Department of Movement Disorders Fellowship, she's an assistant professor at the Department of Neurology. She completed a Movement Disorders Fellowship here at our site at the University of Pennsylvania, during which time she's such a slacker. She had to go and get a master's of science in clinical epidemiology as well. And that just amazed all of us who were working with her that she was not only doing her fellowship, but pursuing a master's also. Prior to joining the neurology department at the University of Colorado, she spent a year as an instructor at the University of Pennsylvania and Philadelphia VA PADRAC program, which is the Parkinson's Disease Research, Education, and Clinical Centers. So Dr. Fullard and I know each other from her time here at the University of Pennsylvania, in which, as I said, we were all very impressed and to get the chance to work with her and see the research that she and colleagues were doing on women in Parkinson's. So I want to turn it over to Dr. Fullard.
Hi, everyone.
I'm going to go ahead and share this too for you. All right.
So I'm Dr. Fullard, and one of my interests is women with Parkinson's disease. So it's one of the focuses of my research. So really excited to be here and talk with you all about a topic that I find really exciting, and I think we need a lot more work in this area. So I just wanted to start out by going over some definitions. If you look at the literature or information that's out there about women in Parkinson's or sex differences or gender differences, you'll see that sex and gender are kind of used interchangeably, although, as you probably know, they're not. So sex is referring to the biological sex, whereas gender is more associated with social, cultural, or personal identification. But again, if you're looking at the literature, looking at information, you may see them used interchangeably, and that's true with any literature looking at women and Parkinson's. So I'll try to use sex throughout this, just talking about the biological sex and the differences between men and women. So we do get a lot of questions about, you probably heard that the incidence is higher in men, and why is that? And so we'll get into all the possibilities there. But as far as all the differences between men and women, the one that's really well established is that the incidence is higher in men. So men just seem to have a higher risk for Parkinson's disease. And from studies, we know that the incidence, and that's a new diagnosis of Parkinson's, is about 1.5 to 2 times higher in men compared to women. And then if we look at the prevalence, so that's just looking at anyone who has Parkinson's at any point in time, again, we see that it's higher in men. And if you look at this slide, you can see the graph there. So at any time point, at any age, men have a higher incidence of Parkinson's. Although you can see when you get out to about age 85, it gets a lot closer. And some of that has to do with women living longer. And then there is some literature, there are some studies out there that suggest women may have a little bit of a later age of onset of Parkinson's. So some have shown up to about 2 years later, although others have shown no difference. And then there's a question of, are women just getting diagnosed later? Are we recognizing their symptoms later? And that's still a little bit unclear, but at least multiple studies have shown that women may be developing symptoms later and might have something to do with estrogen and other risk factors we'll talk about.
Dr. Fullard, some questions that had come in. Do we know why Parkinson's is more common in men?
Yeah, so that's a great question. And if you want to go down to the next slide there. So one factor that may be different between men and women are the risk factors that they're exposed to. So some of the risk factors associated with Parkinson's include head trauma, pesticide exposure, toxin exposure. And we know from different occupational and recreational exposure, men just may be more likely to be exposed to these risk factors. So that may contribute. It's likely not the whole story, but because of these occupational exposures, men may have a bit of a higher risk of developing Parkinson's. Some of the risk factors may also be different for men and women. So if you look over in the left in the decreased risk column, so in about midlife, non-steroidal anti-inflammatory drug use, things like ibuprofen, are associated with a decreased risk of Parkinson's, but that's for men only. So for women, it didn't change the risk. And then if men have higher urate levels, they also tend to have a little bit of a decreased risk for Parkinson's later on in life. But again, that was only true for men and not for women. And at this point, we're not really sure why those risk factors differ, but we just know that they do. And so this probably at least plays into why men have a bit of a higher risk of Parkinson's compared to women. And then something else that, if you want to go down to the next slide, this is a little bit more recent. People have started looking into whether genetic risk factors can be different for men and women. So about 10 to maybe up to 15% of Parkinson's is associated with a genetic risk factor. And, there's a question of, could those be different between men and women? And at least what's been done so far is not very consistent. And as we talk today, you'll hear that a lot. Studies show different findings, but I'll try to talk about the ones that have more consistent findings. So as far as genetic risk factors, there are 2 studies that show that women are more likely to have a LRRK2 mutation. So this is an autosomal dominant mutation, meaning you only need 1 copy to get Parkinson's, but it's not completely penetrant, which means if, say, you get 1 copy from your mom or your dad, doesn't necessarily mean that you'll get Parkinson's. The percentages are, again, a little inconsistent, but somewhere around maybe 30 to 40% of people who have this mutation will actually go on to get Parkinson's. And then in these 2 studies that looked at the Ashkenazi Jewish population and the Italian population, women were more likely to have this LRRK2 mutation than men. And we don't necessarily know why, and something that further studies are looking into. And then there are a few that there are no differences, so that men and women were just as likely to have this mutation. But definitely something worth more study to figure out if women may have more of a genetic load or have more of a genetic predisposition for Parkinson's based on certain genetic risk factors. And then if you don't look at specific mutations, but just look at a family history of Parkinson's in general, several studies have shown that women are more likely to report that a family member, either 1st degree, 2nd degree, or 3rd degree family member has Parkinson's. And so you can see that over in the table on the right. And this was just over 2,000 patients with Parkinson's. And so if we just looked at 1st degree relative, you can see that women were a little bit more likely, they had Parkinson's, to say that they did have a relative with Parkinson's. And if you add the first and second degree, again, women are a little bit more likely to report that, but it didn't become significant until we included all the first, second, and third degree. But again, suggesting that genetics may play a little bit of a different role between men and women in the risk for Parkinson's.
And just a question has come in. I'll be honest too, a couple of you are, it looks like you've raised your hand, and I'm trying to figure out where that is. I apologize, but we did have a question on the last slide. For some reason, I'm having trouble moving the slides too. And so they were asking about dairy. That was shown as an increased risk for Parkinson's, dairy consumption. And someone asked, if we know why this is, and if that means that people with Parkinson's should avoid eating dairy.
Right. So it is something that has been shown to be an association in several studies. So midlife, moderate dairy intake, but it's just an association at this point. We can't say that it's a cause of Parkinson's. Otherwise, we would be recommending to cut it out and to not consume dairy. But at this point, we don't have enough evidence to make that recommendation. It's an association that we need to look more into, and we don't really know why that would be at this point. And we don't necessarily see a difference between intake between men and women.
Interesting. And so for those of you that had your hand up, if you maybe can type it into the questions, that might help me out a little bit. Let's see. Okay. Go ahead. So I'm going to go ahead and forward this. I think I finally found those other questions. I'm having trouble forwarding the slides, and I'm not sure why. Someone said, please don't take away my ice cream.
At this point, you can still put milk in your cereal, still have your ice cream. We just don't have the evidence so far. If we do at some point, then we'd be making the recommendation not to. But yeah.
Nobody's losing their ice cream.
Yeah.
You're all safe. If I can just figure out how to get these slides to move again. That's weird. They were moving and then they're not. There we go. Okay.
So one of the big things that we get asked quite a bit is the role of estrogen in Parkinson's and Parkinson's disease risk. Because obviously one of the big differences between men and women is the role of sex hormones, and estrogen being the predominant one in women. And you can see over on the right side, so estrogen is not completely stable throughout a woman's life, increasing in the 20s, 30s, up to 40s, and then will decrease again around the time of menopause. And so it is thought to play a role in multiple different areas of Parkinson's, including risk for Parkinson's and potentially treatment. And I'll talk a little bit more about that. But we know from animal studies that estrogen may actually be neuroprotective. So if animals are exposed to toxins or injury of some sort, if they also have estrogen or are given estrogen, the nerves are protected. So then, of course, that opens up the door to using it as a therapy. And so that's why there have been studies done looking at that. But what we see in animal studies don't always translate into human studies, but it's something that definitely needs more study. So aside from the potential neuroprotective role, we also know that if we just look at women and the amount of estrogen exposure they have over a lifetime, that can be associated with Parkinson's disease risk. So if a woman has later or earlier onset of menarche, so menses earlier on, and then later onset of menopause, they have exposure to estrogen for a pretty long period of their life. So women with longer exposure, up to 39 years is in one study, have a decreased risk of Parkinson's disease. So it's thought that that longer exposure to estrogen was actually protective. Whereas women who have later onset of menses or menarche and earlier menopause, so they have less exposure to estrogen throughout their life, may be at an increased risk for Parkinson's disease. And then we also see that with people who maybe have an oophorectomy, so have their ovaries removed, and so they're having surgical menopause earlier on. Some studies have shown that they might be at a little bit of an increased risk of Parkinson's as well. Something that needs more study, but several studies have shown that decreased lifetime exposure to estrogen may increase your risk for Parkinson's. And something that I found interesting, because it's a little bit of a paradox, for women who have 4 pregnancies or more, may actually be at a little bit of an increased risk for Parkinson's. Again, we haven't proven that, it's just an association we've seen. But it's thought that because it's a different kind of estrogen that's elevated during pregnancy, and then in the postpartum period, you have a big dip in estrogen. So if you have 4 pregnancies, then you have 4 postpartum periods where you have a pretty low estrogen level. So the hypothesis is that that may contribute to the risk for Parkinson's.
We've got some questions coming in too.
Yeah, sure.
So on that note, one of the questions that came in from Kim is there any chance that hormone, replacement therapy would slow the progression at all? Or, and someone else asked if hormone suppression therapy would help decrease the risk.
So those are great questions, and something that unfortunately right now we don't have a great answer to. There have been several studies looking at using hormone replacement therapy to treat Parkinson's. So there's one study, and it may be a few slides up, but it's called the Poetry study. It was only 23 patients with Parkinson's. They were postmenopausal, and they were given estrogen replacement therapy. And they actually had an improvement of 5 points in the UPDRS. So that's that motor score, or the Unified Parkinson's Disease Rating Scale. So if you have Parkinson's or have been to a visit with somebody who has it, it's where we have you do these things. And then we get a score at the end of that. And women who were given this replacement therapy actually had improvement in their motor scores. But then there have been other studies and other larger observational studies showing that there's no improvement. So at this point, we really don't know. And because there can be risks associated with hormone replacement therapy, it's not something that we would typically just recommend for the sole purpose of treating Parkinson's. Now, if you need hormone replacement therapy for other reasons, for other medical problems, and your doctors have decided that the benefits outweigh the risk, then something you may notice is that Parkinson's symptoms might improve. But hopefully that's something that we'll get a better answer to in the future.
Very interesting. Someone asked if estrogen helps cure Parkinson's. And I think at this time it's safe to say that there is no cure for Parkinson's, but it sounds like in some studies there was some improvement that was shown with motor symptoms.
Right. Yeah, so it may play a role, or it may play a role in the decreased risk among women, but at this point we just don't have enough evidence. And then there's also this theory of a critical time window. So if there have been some studies showing if someone goes through menopause, that in order for the hormone replacement therapy to be beneficial, they would need to get that therapy right away rather than several years later. And this has been shown in some animal studies as well. So if you go through menopause and say, so your estrogen level has dipped and there might be some, you might lose some neurons, or the neurons might not be as healthy, and then you add in estrogen with estrogen replacement therapy, it may no longer be beneficial to nerves that are no longer healthy. So, and again, this is all just either animal studies or observational studies. We don't have the direct link, but one of the hypotheses is that estrogen is protective of healthy neurons, but once they're no longer healthy, adding in estrogen therapy may no longer be beneficial.
Very interesting. Okay, let's see if I can move this forward. It's really weird how it's kind of sticking. Apologize. Strange. I apologize, guys. It's for some reason, it's not what it here goes. Got it again. Thank you. Thank you for your patience, guys. I apologize.
So something else that we see, and this is a smaller population, so about 3 to 5% of women who are diagnosed with Parkinson's are under the age of 50. And people who are under the age of 50 with Parkinson's do have unique experiences because they may still be having menstrual cycles, and that the changes in hormones during that time can really affect symptoms and treatment. So what we've seen, and as you can see over on the right side in the graph, so the red is estrogen, and you can see a dip in estrogen around the time of ovulation, but then again, it gets much lower around the time of menses or around the time of your period. And so that's when we see an increase in symptoms in Parkinson's. So it does seem to be related to estrogen again. And so some people may notice an increase in symptoms, decrease in responsiveness to medication, and may have increased off time because of that. Things that can potentially be helpful is increasing medication around that time. Although I do have patients who say, no matter how much I increase, I just don't respond to the medication around this time. And then there are some people, because if this is happening every month, you know, it's almost a week out of your month, every single month, can really affect you and how you're functioning. And so some people do find that starting an oral contraceptive pill may be helpful, one that has estrogen and progesterone to kind of keep the levels steady so you're not having those fluctuations. Although we do see that some people who do start an OCP or the oral contraceptive pill actually say symptoms get worse on the pill. And so sometimes it's just a little bit of trial and error and seeing what works for you.
Interesting. So someone had sent a question in ahead of time. You know, the symptom worsening during menses, loss of iron. It sounds like hormones, we believe, is related. Is there possibly poor med absorption due to, you know, changes in bowel habits with the hormones, or anything from that?
So, you know, we don't have great evidence for it so far. I mean, potentially a change in absorption if you are having, say, more constipation or something else around that time. But what we think it has to do with estrogen's effect on dopamine receptors and keeping dopamine around longer. So if you're having a dip in estrogen, at least from animal studies, we know that that will cause you to have less dopamine receptors. Dopamine can be broken down faster, which might be why you're just not as responsive, because you don't have as much around. And then the receptors where the dopamine is actually acting to improve the symptoms, you don't have as many of those. So that's all theoretical at this point, but one of the hypotheses of what might be going on. And then in addition to just the Parkinson's symptoms getting worse, if we compare women with Parkinson's during menses compared to same age women without Parkinson's, people with Parkinson's actually report more fatigue during their period, more cramps, and a heavier menstrual flow. So it seems to also affect the menstrual symptoms themselves.
And Michelle, we're getting a lot of questions around progression of Parkinson's as well. So it sounds like in some of the literature, there is a suggestion that women do progress more quickly. Is there any thought that estrogen would help slow that progression? Or, you know, do you feel it is consistent enough in the research to say that women do progress more rapidly than men?
Yeah, so that's actually a little bit all over the place, depending what study you look at. There are some studies that actually suggest women may have less progression or slower progression because they do tend to present more with tremor. And we know people who have more tremor predominant Parkinson's progress more slowly. And then there are studies that show no difference over 5, even up to 10 years in progression, as far as what we can measure as progression. So those motor symptoms when we're doing the UPDRS, for the most part, do seem to be pretty similar. Although women do report more disability, lower quality of life. So in that regard, then there may be more progression in those symptoms compared to men. And at any time point, women, even with the same motor scores, same motor symptoms, do tend to have a lower quality of life and more disability. And as far as the role of estrogen, there is a suggestion that progression may speed up around the time of menopause when the estrogen is dipping. But again, those studies are pretty small, so we can't make firm conclusions based on that. But it is possible that more symptoms would emerge or worsen at around the time of menopause. And then because at least some of the smaller studies have shown that estrogen replacement therapy may improve symptoms, it may improve symptoms. We don't know if it's just symptomatic or if it's protective and slowing progression. So that would be what we would look at with more studies. But there's that potential. If it is neuroprotective, then there's a potential it could slow progression.
Now, a question that's come into is, do we understand why the tremor predominant type of Parkinson's is a slower progression?
No, we really don't. There may be some differences in genetic predisposition, And, you can actually change. So if you begin as tremor predominant, over time, the tremor may lessen and you may become more akinetic rigid, so having more stiffness and slowness. But as far as if you start out tremor predominant, we really don't know why people are more or have less progression or slower progression.
Gotcha. Excellent. Thank you guys for the great questions. And then I noticed here too that the increased off times, is that consistently around menses, or do women have more problems with motor fluctuations in off times?
So in general, women do tend to have more off time, and we can go to that side in a minute as well. But around menses, it's fairly common for women to report more off time, just more symptoms in general, and less response to medications. But we do certainly get a lot of questions about treatment and side effects to treatment. So it looks like slide 15, if you wanted to go there, we could go ahead and talk about that. But in general, so if we look at medications that are prescribed for Parkinson's disease, in general, women get about the same medication. So Sinemet, or carbidopa-levodopa is one that's typically used. The dopamine agonist, there are some studies showing that women might be more likely to be prescribed those. But in general, the kinds of medications are pretty similar. The levodopa, so the carbidopa-levodopa, it actually has a higher bioavailability in women, meaning if you took the same dose as a man, what entered your circulation would actually be higher than a man. So that may play into some of these side effects that I'll talk about. And then just in general, women tend to have a lower weight. And so that may also contribute to some of these side effects. But while those might contribute, we don't necessarily know why women have more side effects. So we do know that, so if you take levodopa, there is the risk for having dyskinesias. Typically that's 5 or so years after disease onset or after starting levodopa. Seems to be more related to the actual disease stage and not necessarily when you started the medication. But we do know from studies that women tend to develop dyskinesias earlier on, so maybe even up to a year earlier than men. And women also tend to have more of the motor fluctuations. So when the medication kicks in and it's at its peak dose, they may have more of the dyskinesia, and then it may wear off earlier. So they, like you were saying, Julia, women with Parkinson's may have more off time. They just have more of these ups and downs than men who are at a similar stage or similar duration of Parkinson's disease.
And an issue that we see come in quite a bit is, a lot of women I find, especially, that are younger at diagnoses, want to avoid medication as long as possible because they're very fearful of the onset of dyskinesia. And I've even seen at times that it can, be to the point of creating some level of disability, like people having to stop work or, stop their careers or inability to do certain daily tasks themselves, like trouble with, handwriting or typing or fine motor things. And, at what point do you, how I guess you have the conversation and kind of guide women through, at what point is it time to take the medication? And weigh that, I guess, over the fear of the onset of dyskinesia.
So that's a question that we get asked a lot. And so in general, since the medications we have are symptomatic therapy, they're just going to improve symptoms. They won't slow or change the progression of the disease. So I typically talk with people about how they're functioning, how they're doing, if there are things that they can't do because of their symptoms. And that's usually the point where we're talking about introducing medication. Because the goal of therapy is to keep you functioning as well as possible, able to exercise, since we know that is something that can slow progression, and able to do your daily activities and be as functional as you can be. And so if you are having a lot of disability because of your symptoms, or there are just a lot of things that you would like to be able to do but can't because of symptoms, that's typically where we're really having a serious conversation about starting medication. And because we think at this point that dyskinesias tend to occur because of the stage of the disease and not necessarily how long you've been on levodopa. It doesn't necessarily mean that if you start it earlier, you'll get dyskinesias earlier. There might be a little bit of wiggle room there, but there was actually a good study that came out of Ghana, I believe, compared to an Italian population. So in Ghana, they had much less access to levodopa. And so they were starting medication for Parkinson's 5 to 10 years after disease onset. Whereas in Italy, they were starting it pretty soon after diagnosis. And no matter when the medication was started, people with Parkinson's were getting dyskinesia at pretty much the same time. So we really do think it's about the disease progression in the brain rather than how long you've been on levodopa, although the dose of levodopa can certainly at any given time increase your risk for dyskinesia, which then we can try to adjust medication doses to reduce it. But part of what I think you're asking is because dyskinesia is more common in women, happens earlier, should you try to get away with medications for longer? Again, we're trying to keep people as functional as possible, feeling as good as possible. So, introducing medication, even if you do develop dyskinesia, there are other therapies that can help. We do have medications that can kind of suppress dyskinesia. And then there's also deep brain stimulation surgery and some of the other advanced therapies that women tend to underutilize. So men are much more likely to get those therapies, even though women have more of the complications of therapy that are indications for DBS. So we're typically recommending DBS when people are having a lot of fluctuations, a lot of off time, a lot of dyskinesia, which again is more common in women, but women are less likely to get DBS.
Why do you think that is?
Yeah, so that's a good question and something that we're exploring more. It's probably a multitude of factors, maybe referral bias. So women just aren't getting referred for DBS. Physicians may not be bringing it up as an option, maybe a lack of awareness of it as an option. And then there may be patient factors as well. So women may be maybe more risk averse or not wanting to go through surgery compared to men. And we do have one study that actually looked at that. It was smaller, so hard to make big conclusions from it. But it did show that men and women were actually just as interested in getting DBS. So it looks like there at least is some differences in referrals to DBS and maybe at least talking about it and talking about a referral.
Interesting. So it sounds like, we've gone, I think, a lot through some of the different, symptom presentations and genetic changes and things like that. But is there really, do you think there's a disparity, or not necessarily a disparity, but a difference in care or the approach to care that women receive versus men?
Yeah, so there does seem to be. And so one is DBS, like we were talking about. So even though it is a great therapy for Parkinson's disease, and again, good for when you're having those fluctuations, we're tending to use it earlier than we used to. So we don't see it as, a therapy of last resort. It's more of just a good therapy for Parkinson's, kind of around the middle stage. So women are less likely to receive DBS. So that's one. And then if we just look at access to care, so if we look at men and women from the time of symptom onset to the time that they're diagnosed, tends to take longer for women to get diagnosed. And some of this may be more implicit bias. So if you were to Google Parkinson's disease and look at pictures, oftentimes it is an older man that you see. And so other physicians who aren't as or don't see Parkinson's as much may just have in their mind that Parkinson's is a disease of older men. And so it's harder to, see a woman and think about Parkinson's. And then sometimes symptoms of menopause are attributed, or symptoms of Parkinson's are attributed to menopause, because sometimes there is an overlap there. So you can have an increase in sweating with Parkinson's. You can also have that with menopause, increase in fatigue, and then increase in depression, anxiety. All of that can come along with Parkinson's and with menopause. And so if you have those symptoms and a physician or somebody thinks those are more related to menopause, then you may have a delay in diagnosis. But we do definitely see that it tends to take a bit longer for women to get diagnosed. And then if we also look at symptom onset to the time that someone sees a movement disorder specialist, it also takes longer. So in one study, it looked like men and women, when they had symptom onset and recognized that they were having some symptoms that they wanted to get checked out, they saw their regular doctor within 3 to 4 months. So that was all pretty consistent. Then referral to a specialist, or at least getting in to see a specialist, men tended to get in within 1 year. It took 2 years for women to get in to see a specialist.
Wow.
And yeah, so, and that's going to delay care. It's going to delay just, giving information about Parkinson's and other therapies, exercise, physical therapy, occupational therapy, all the things that we know can help with symptoms that a specialist is more likely to be aware of. But what we don't know is why. So we don't know if it is a referral bias, if women just are less likely to get referred, which is probably part of it, or is it that women have other obligations? Just traditionally, women tend to be the caregiver in their family. And so if they're taking care of other people, they have less time to take care of themselves. So maybe they are also just delaying that referral to a specialist because they don't have the time, or maybe they don't have someone to drive them to that appointment. So it might be other factors involved as well.
I think we can all relate to that as women. I mean, so often my husband was scolding me because even just things for me, like going to the dentist, like I should, or getting a haircut, I think we all tend to put those things off. So that's interesting.
Mm-hmm.
A question here that came in, there's a few on, is dystonia early onset of a dyskinesia? And kind of, I guess more the question is, what is the difference between dystonia and dyskinesia?
Mm-hmm. So, it depends too. So dystonia can come along with dyskinesia, or in younger onset Parkinson's, dystonia tends to be one of the presenting signs. So you might have dystonia, so turning in of a foot or curling of the toes. That might actually be the presenting symptom of Parkinson's in the younger population. But then as the disease progresses, if you are having more of those fluctuations, you can actually get wearing off dystonia. So as the medication is wearing off, dystonia may come out. And then sometimes people actually have on dystonia too, where an increase in the medication actually can cause it, but more likely to happen when wearing off. And that is also true of dyskinesia. So oftentimes we think of dyskinesia as you take your medication, the levels increase in the blood, and then you get the dyskinesia, or those extra wiggling movements. So that is the most common, but then you can also get dyskinesia as you're wearing off. And so we call that diphasic dyskinesia. And so that can happen at the same point that dystonia may happen too.
Excellent. Thank you so much. For some of you that are sending questions and are raising your hand, we'll take those at the end when I do the stop share on the slides, if that's okay. I thought this was really interesting, the information that you put in, Michelle, on care partners.
Mm-hmm.
And so can you go a little bit into what it looks like? We talked about the difference in care. They're not seeing a specialist or getting DBS maybe as often. So what happens? What's the difference in the care partner relationship or caregiver?
Right. So one of these studies actually came out of Penn. Nabila Dadadwala did a study looking at care partners in Parkinson's disease and who was more likely to have a care partner and who those care partners were. And so what we know from that study and other studies that have been done is that women are just in general less likely to have a care partner. And this is true of Parkinson's, but also of other chronic diseases. So women tend to have less support through a chronic disease. And for a variety of reasons, women are less likely to have a spouse as a caregiver. We do know that women have a longer lifespan, so it just may be that they're widowed and the spouse isn't around. But then there's also, because women tend to be the caregiver in the family, it just may be that the spouse isn't the caregiver. And then because of that, women are actually more likely to have a paid caregiver. So if they do have one, they're more likely than men to be paying a caregiver. And in general, if you look at the number of hours that a caregiver is with the person with Parkinson's, women have many fewer hours compared to men who have caregivers. And just going along with that, women are more likely to attend appointments alone. And maybe because they don't have a caregiver. And then some women have said, didn't even think about asking someone to come to their appointments. And so something to think about too, if there's a family member or a friend or someone who can accompany you, just to help you get the information, make sure you're getting everything that you need out of the appointment and asking for help when you need it too.
We see that a lot, actually, even in therapy. I have to admit, men a lot of times will come with a care partner, but women typically come alone. And a thing that we hear often, and I'm wondering if there's anything in the literature that supports this, is that they don't want a burden, that they don't want to be a burden to their care partner. So I'm wondering, do you think that, or is there anything that suggested that there's an increased perception in caregiver burden by women versus men?
So I'd say anecdotally, for sure, I definitely hear that quite a bit as well, that women are saying they don't want to be a burden and do tend to come to appointments alone, go to therapy alone, tend to just do and keep doing a lot more on their own. There is some literature, though, looking at care partners of people with Parkinson's, and when a woman is a care partner, they actually have a higher caregiver burden compared to a man who is a caregiver of a woman. And so that goes both ways as well. So women tend to potentially take on more of the burden for caregiving when they are a care partner as well.
Very interesting. And then it looks like you go into health service use a little bit. I've already kind of touched on this. And I believe there was a recent study that came out where they were tracking from the Parkinson's Foundation access to therapies even. And they were saying that women access therapies less than men as well. But what do you notice are the big differences in the service you use?
So this was actually data from a study that I did while I was at Penn with Allison Willis, and this was using Medicare data. So these are people with Parkinson's who are 65 years and older and have Medicare as their insurance provider. And what we found, and this was already known in the literature, is that in general, women have fewer physician office visits, which can be primary care for any variety of reasons, and also less likely to see a neurologist. And the problem there is that we know from other studies that people who see a neurologist or have a neurologist involved in their care are less likely to go to the hospital for Parkinson's related reasons, less likely to get readmitted to the hospital, less likely to have hip fractures. And so, there's reason to be concerned that women aren't as likely to have a neurologist involved in their care because it may affect outcomes. And then in this study, we also found that women were more likely to use skilled nursing facility care and more likely to use home health. And we think at least part of this, again, goes back to the caregiver issue. So if women are less likely to have a caregiver, less likely to have help at home, then they may need that skilled nursing facility care more often than men, or need home health more often than men. So I think we have a long way to go in supporting women better with Parkinson's disease. Because not only are women having to use some of these services more often and maybe being hospitalized more often, it can just affect outcomes in general.
Do you find that there's a different access? A question came in for people with young onset Parkinson's. So for women, do they access care less, or are their services look any different and as the condition progresses?
So we don't, because younger onset Parkinson's, and especially in women, it's so fewer, it's not as well studied. So we don't know for sure based on the literature. In general, younger people are accessing health services less. We know, at least in our older population in Medicare, men and women were accessing physical therapy and occupational therapy at the same rate, but women were less likely to see a speech therapist. But as far as younger onset Parkinson's, we just don't have that data. But so I don't know that I can really say. But at least anecdotally, potentially less.
And as a question came in, could it be because it's during work hours? And I think for sure, with younger, people you're trying to work and maintain usually a family life or, caring for children. And a lot of times those hours, in the day when you could see a doctor, it becomes very difficult, especially if maybe time off or, family responsibilities conflict with that. So I think that is probably a mitigating factor for people with young onset.
Yeah, exactly. We definitely see that quite a bit, and that can definitely be a barrier to accessing care. We also hear from a lot of our younger onset Parkinson's patients, men and women, that they find it's harder to go to support groups because they feel that their needs aren't necessarily represented because a lot of the participants are older or have more advanced disease. And so we're trying to get more support groups that are just younger onset, so you have more of a peer group and more support from that angle.
Absolutely. I facilitate a PD self group, which is for newly diagnosed, and a lot of the people are younger, and we do it on the weekend because it is really important that access, it's there. I wanted to feel like it conflicts with people's work or family lives as little as possible. So that's fantastic. And then I know we've had a lot of questions. The next slide is on research, and so much research in Parkinson's is around exercise. And some of the questions that have come in are around, are there differences for exercise for women and men? And what is the research around women's issues?
And so that's something we're actually planning to look into. Because of the way that some of the exercise trials are designed, you power a study based on, so you look at the number of participants that you need to show that a certain effect is significant. And so all these studies have been based on the total number of participants. And if you then break that down into men and women, you lose that power. So if we try to look at just women compared to just men in the exercise trials, we can't really say if any differences we see are significant. So that's one of the problems in not just exercise, but in Parkinson's research in general, is that we just don't have enough women involved. And more research is needed just to identify those barriers because of what we've already talked about. Women are less likely to have a caregiver, more likely to attend appointments alone. So those can be barriers to just getting to research studies and getting involved if you have other obligations at home or no one to bring you to those. So we really need to figure out how to design studies so that women can participate so that we can really answer some of these questions and figure out what treatments and what lifestyle changes are beneficial for women. Because at least from some of the literature, we know that because of gait changes and maybe even cardiorespiratory issues, women may not tolerate exercise as well, and especially high intensity exercise. But what we don't know is if women are benefiting from exercise as much as men, because we just, based on the trials that have been done, haven't really been able to look at that yet. But something we're hoping to pool all the data and hopefully look at that in the future.
Very interesting.
And along those lines, I mean, we do see when we look at all the Parkinson trials that have been done, it's the majority of them are men. And so a lot of the treatments that we have, a lot of, again, the lifestyle changes that we recommend are based on what works for men. And if you look at the percentage of men in each trial, it is higher than what you would expect based on the split in the population of men and women with Parkinson's. So, we really need to figure out how we can make trials work and make them accessible to women so that we can answer some of these questions.
And that's fairly consistent across healthcare, correct? It's not just Parkinson's, but often, a lot of the research, be it cardiovascular interventions or diabetes, it seems like a lot of things are, they're recognizing now. I think this is a new trend in healthcare, the need to do, gender-based research, but this is, I think, rather new, would you say?
Yeah. And so you mentioned cardiovascular research. So for a while, women didn't have nearly as good outcomes as men. And it wasn't until there was a big push to get women into cardiovascular research and trials that outcomes started really improving for women because everything was driven by the number of men in research. So we might see something like that in Parkinson's as we start enrolling more and more women. and focusing.
Somebody had sent a question across to, they're a working mom and trying to participate in research. They said they'd gone on the Fox Trial Finder and been unsuccessful. One that I typed back to her was clinicaltrials.gov. Are there other resources that you would recommend if women want to get involved in research to try to help build the pool a little bit?
Yeah, so those are the main ones, but then just talking with either your neurologist or movement disorder specialist, because they should also be aware of what's going on. And if you are being seen at a larger center, there's likely trials going on there that they can talk with you about and see what you might qualify for. And then we often have, if anyone says they're interested in research, then we have one of our coordinators reach out and they'll go through all of the studies and see what you might qualify for, what actually makes sense for you. You know, if you have to come for a visit every week and you're working and like you said, you're a mom, that probably isn't going to work out. But if there are visits that are, once or twice a year, or ones that you can do through telehealth or don't even have to come in for, those might make more sense. So I think we just need to be more cognizant of that too.
Absolutely. Okay. All right. So what I'm going to do now, if it's okay with you, Michelle, unless you want me to go back to anything, is stop share, because I know some people have been raising their hand and I wasn't able to find out how to allow that question to come through. So I'll see if I can find that now. Let's see here. And then also there's some questions that have come in that I'll kind of pull up too from the chat and kind of see some other ones as well. So one that I thought was that we didn't get to, I think I kind of skipped past it and some of the issues that I was having, but this is just a good one to take down the slides a little bit and talk about it, is sexuality. Mm-hmm. Are there difference? One of the questions, I love this too, this community, you guys just come through and ask, you're not afraid at all. Is there any impact on the woman's ability to orgasm with sexuality and Parkinson's?
Yes, so we definitely do see that it can affect sexuality in a multitude of ways. One, it can definitely affect your ability to achieve orgasm. Along with menopause, but potentially Parkinson's itself can contribute to vaginal dryness, low libido, which can be, so less desire, can come along with Parkinson's, but also any chronic disease. And then also pain with intercourse. Some people can be either embarrassed or concerned about bringing it up with their physician, but I would definitely encourage you to, because it can have a big effect on you, on your relationships. So being open with your doctor, being open with your partner, because it's not only those ways that it can affect your sexual health, but just Parkinson's symptoms itself. So slowness, mobility issues, all of that can affect your sexual relationships. And so working with your doctor, and then we have a sex therapist here as well that can be very helpful, and or seeing your gynecologist if you need some kind of hormone replacement therapy for certain things. But we do definitely see that it can affect sexual health. And something that, we probably don't do as good a job at asking people about, and we probably should ask more.
Absolutely. Absolutely. And, I think that something that's coming out too, that for a lot of women, cost can be a factor around maybe, seeing a sex therapist sometimes, or different interventions or therapies may not be covered by insurance. So that can be difficult. So I think too, and if you disagree, Michelle, correct me, but don't hesitate to talk to your doctor, not only about these issues, but let them know if cost is the barrier. Like, I would like to see a sex therapist, but I really can't. There are other resources you would recommend, or other suggestions. I think that we always, as healthcare providers, want to recommend what's optimal, but we want to understand financial limitations or problems that you might have as well. So don't, be afraid to speak up and say that to your physician as well. I'm unable to figure out, I'm going to be really honest, how to do the people who have a raised hand. So I'm really, really sorry. So that it's just not showing up for me here for some reason in the usual spot. So some other questions that had come through too, that I just want to make sure that I get to, is one lady specifically asked, kind of to the topic of around sexuality, but around urinary incontinence. incontinence. So a little different with that area. Do you recommend any strategies for managing urinary incontinence? Because I know in the one slide you had, it speaks to it being more common, I guess, or more of an issue for men, I believe. But if a woman is experiencing that, what do you recommend?
So one of the first things we have to figure out is what kind of incontinence it is. So there's stress incontinence, which tends to be more common in women who have had pregnancies and multiple pregnancies. So the pelvic floor isn't strong enough. So say you sneeze or cough, you may have some leakage of urine. And so that's pretty common in the general population as well. And then there's more of the neurogenic bladder, where your bladder is overactive. And so you may feel like you're going all the time, but not much comes out. Or when you feel that you need to go, you have to get to the bathroom right away. So that urgency. And so there are actually medications that can be used to treat that kind of incontinence. Some that sometimes we do prescribe if we're pretty sure that's what's going on, and can be related to Parkinson's. If there's a question, then we may send you to a urogynecologist or something like that for further evaluation, just to make sure we're not missing something else or there's not a better therapy. But there are certainly medications that can be used for that kind of incontinence. Some that do have what we call anticholinergic effects, and can affect your cognition. So something to always let your neurologist know if you're being started on one of these medications, because there are some that, at least one in particular that's less likely, or the myrbetriq is less likely to cause the cognitive problems. And then the other kind of incontinence is what we call overflow incontinence. So your bladder has less tone and you're just unable to empty it as well. So then when it gets full, then you're emptying without realizing it. And so that is probably when we would send you to a urogynecologist as well for further evaluation and treatment.
Do you ever recommend or refer people for pelvic floor therapy if you feel that it is more of a pelvic floor issue for women?
Yes, yeah, we certainly do. Yeah.
Excellent. And I know something that I sometimes recommend with the neurogenic bladder that people find helpful is going on more of a toileting schedule. So kind of at when you void and because it seems like sometimes it's a little bit of a signaling by the time you get the signal, and who knows if it's maybe mobility as well, if you have freezing of gait or difficulty ambulating to the toilet, kind of going before it's really, you feel the urge to go, kind of going on more of a schedule can be helpful.
Yeah, we've definitely found that's helpful. Yeah.
Excellent. And then let's see, there was one more question I know I wanted to get in here before we finish up. And that is, you know, someone asked here kind of, what is the biggest surprise that you have learned from working with women in Parkinson's? Or I guess what has been most surprising for you?
So, I mean, one, before I was really delving into the literature, just how long it really took for women to get diagnosed. I mean, when I was seeing somebody, they would detail, you know, I was sent to this doctor and then I was sent to this doctor and no one knew what was going on. They thought it was menopause. They thought it was anxiety, and it just took so long to get the diagnosis, and just, you know, everything that you had to go through to get that diagnosis, to even begin treatment and to figure out what was going on. So now I'm looking at the literature, it makes more sense, but at least in the beginning, I was definitely surprised how long it took.
Absolutely. I find that too. And a lot of, I was going to ask you about the anxiety piece, because a lot of women have reported to me that they would, you know, note a tremor in their hands to their, you know, general physician or whatever. And then, oh, it's, you know, probably anxiety. And sometimes they were even recommended or prescribed medications for anxiety around it. Do you feel that happens as often for men, that kind of assumption of an anxiety with a tremor for women?
It definitely seems more common in women. And I mean, just in general, though, women are more likely to have anxiety, which probably plays into it. So women are more likely to have anxiety in Parkinson's, but also in the general population. So I think because of that, a lot of times symptoms are just attributed to anxiety, whereas in men, much less likely for that to occur. And I think that just comes along with some of that implicit bias, the picture you have in your head of Parkinson's when you're seeing somebody.
Absolutely. And someone had also asked the question of essential tremor. Is it ever related? Like if someone has a family history of essential tremor, are you more likely to get Parkinson's, or kind of what is the relationship with those two conditions?
So there's a little bit of controversy about that. There are some studies showing that If you have essential tremor, you might be a little bit at a higher risk for getting Parkinson's. If you have Parkinson's, again, might be a little bit of a higher risk for essential tremor, but that it's not clear. We really don't know. And as far as the family history, you know, if you have a family history of essential tremor, you're more likely to get essential tremor. Haven't really associated that with Parkinson's yet, at least consistently. But oftentimes we do actually see Parkinson's diagnosed as essential tremor in the beginning before you finally get a diagnosis of Parkinson's disease. So we see that too.
Excellent. All right. And then one last question, and then before we close it up. So what do you think are the biggest challenges that women with Parkinson's face, and how would you recommend that they address those challenges?
So I think it's a lot of what we talked about. So one, even just getting the diagnosis, so getting into the doctor. So, you know, advocating for yourself and having somebody come with you to your appointments to make sure they're advocating for you as well. And making sure your doctors are completely aware of all of your symptoms, not being afraid to bring those up. And then again, I think trying to get the support that you need and not being afraid to ask for it. Because I think as women, you know, a lot of times we do tend to do more on our own or try to, but making sure you do have that support system. And, you know, talking with your doctors if you don't, so that we can look into other resources too. Just letting, again, your doctors know all of your symptoms to make sure that we get the care that you need. And I think those are some of the big ones. And I think, you know, if we need to be better at designing studies that women can participate in, but you know, participating in research if you're able to, so we can really figure out what treatments and what lifestyle changes work well for women compared to men.
Absolutely. Absolutely. Well said. Thank you all so much for joining us. Thank you, Dr. Fullard, so much. I apologize for the technical difficulties. I'm presenting this from work, and I do kind of think that maybe our firewalls and security were in the way a little bit of things. So if you have additional questions, of course, you can send those in following the webinar. It will be posted for you to watch additionally, and I believe the slides will be posted as well. And then if you have questions directly for Dr. Fullard, you can send those to her as well. But I hope this was such a great topic. And I think that we're going to see, just like with cognition and a lot of other areas with Parkinson's, I think women in Parkinson's is really an emerging area of study and discussion. And so we'll keep this up, and hopefully there'll be many more of these to come. All right. Thank you so much.
Yeah.
Absolutely. Take care in Colorado. It's great to catch up.
You too.
Bye, everyone.